This is so this is one of this is one of I always say it's one of the best things about being on faculty is you get to invite people you like and impose their ideas on a bunch of your colleagues. So today we've got Dr. Scott Aaronson, whose official title is Chief Scientific Officer of an Institute for Advanced Therapeutics, and I don't remember the best at Sheppard Pratt, which for those of you who don't know, is one of the last remaining major freestanding psychiatric treatment centers. That's all they do as a corporate entity. In their case, it's really an international Catholic area. But what I think is important for people to understand is Scott is basically one of the longest surviving veterans of the war on depression. So before he got into psychedelics, which is what we're going to talk about today, he was one of the pioneers of vagus nerve stimulation, which of course, half the people in this room I know very well the power of VNS to change lives. But it's worth remembering that it was Aaronson 2017 that said, no, these are the long-term outcomes. This stuff gets 2/3 of people better if you just give it a chance. That's what breathed new life into the field. That's what gave us things like recovery. Hundreds of thousands of lives. But he was reminding us at dinner last night that his life on the cutting edge goes so far back that back as a very junior trainee, he was working with this radical new drug called fluoxetine that nobody had ever heard of back then. So really, if there is anything we use as a tool in our antidepressant armamentarium today, it's a good chance that Scott has touched it. And of course, having gone drugs to devices, he's now back to doing drugs. And so in this case, we are going to hear about the tidal wave of psychedelics that is about to make landfall any year now, and what we had better be prepared for. So join me in welcoming Dr. Aaronson for what's going to be, I hope, a really educational talk.
Thank you, Alec. And Alec and I have been buddies for well over a decade. I'm not sure exactly when we first met, probably at some damn meeting someplace, but we've stayed friends. And as Alec mentioned, I have spent my entire career dealing with all the people nobody else wants to deal with, people with really difficult to treat mood and anxiety disorders. And it's the reason I'm not retired yet is kind of because of this, and also a lot of my VNS work. My joke about my career is I'm at the tip of the spear for both the longest treatment for depression, which is VNS, and the shortest treatment for depression, which are psychedelics. So spanning a whole lot of stuff. I will mention a couple of disclosures. The most important disclosure is that a lot of the work I'm going to be talking about has been funded by investigator-initiated protocols and had funding from Compass to look at some of these specific difficult-to-treat populations within depression. And we'll try to give you some color commentary, because I know a lot of you are interested in psychedelics, interested in setting up studies about it, and at least give you my perspective as to how it gets done, because it's really a critical and difficult time for psychedelics, because as much as there is data starting to come out, there's a lot of different parties with very, very different agendas, depending on whether you want everybody to have access to psychedelics, or you're trying to sell your company's product and make as much money as possible. For me, I'm just trying to make some really sick people better and functional. So you're going to get very different opinions based on what chair you're sitting in. How are we doing with major depression? I was joking with my friends at dinner last night that I want my epitaph to say he tried to make psychiatry suck a little less, because we really suck. And we really suck because we have this arrogance that we're really so good at treating depression because we have all these antidepressants, and we've got 30 different antidepressants that all do the same damn thing. And if you don't respond to serotonergic or aminergic support, you're really out of luck. And when you look, we really haven't had much in the way of new antidepressants coming out from, anybody know when the first tricyclics came out? Was 1959. So I was 3. I was not doing research yet. 1959 all the way to 2019, we did not have any novel mechanisms of action of antidepressants coming out. Since then, we have a couple of new treatments, and we also have some neurostimulation treatments, and how Alec and I became acquainted. But the time is really overdue to find treatments that are better tolerated, work more often, more quickly, and are more enduring, and do something other than block reuptake of serotonin. So where are we at present? As I mentioned, for 6 decades, we've been limited to the monoamine hypothesis, which targets serotonin, norepinephrine, and dopamine. And we really do a crummy treatment for dopaminergic-related depressions. Alec and I could fight about whether pramipexole actually works. I have never found it to be particularly helpful. Some folks have. We also have NMDA antagonism. We now have a couple of compounds available, particularly ketamine and esketamine. And we also have some of these GABA A-related drugs coming from Sage Therapeutics that have an approval for postpartum depression, but have not gotten an indication just for straight up depression, but at least it's a novel mechanism of action. Neurostimulation has gotten to be a big deal. And, you know, I never expected to be a neurostim guy, but when I first got down to Sheppard Pratt in 2001, and there was nothing particularly novel within treating depression, is friends of mine who had actually escaped from Eli Lilly to work for startup device companies both asked me to come on to do a VNS study with Cyberonics as well as a TMS study with Neuronetics. All of a sudden, I've been a device guy now for 25 years. But so we have neurostimulation, and we may be able to treat a number of patients with inadequate responses to medication. And biological and psychological therapies have been largely separate in most research as well as clinical care. And one of the coolest things about the development of psychedelics is we're actually finally seeing a remarriage of psychotherapy and pharmacotherapy. Not everybody has bought into this yet. So you get to be old and you start having all kinds of friends. So Carlos Zarate and I have been friends for a long time, and Carlos and I are at a meeting together, and he leans over and he goes, "Hey, Scott, have you thought about doing a study of psilocybin without therapy?" To which I lean back and I go, "Hey, Carlos, have you thought about doing a study of ketamine with psychotherapy?" And in some ways, I love Carlos, but I got to say he has this short-sighted biological approach when we're looking at a variety of medications that does include NMDA antagonists that are opening a cognitive pathway that if we don't exploit it with some kind of psychotherapeutic interaction, you actually don't get benefit. The same way that, I give the example of how many people go to a rave, take whatever drug they're passing out at the rave, and leave the rave more psychologically healthy than they went in. I would posit none, because even though you're taking the drug, it's not within a context that enables you to actually grow from the experience. And I think that psychotherapeutic component, both education and integration, is really essential. And I worry about this dumbing down that particularly industry wants, so they don't run into the same buzzsaw that our friends at Lykos ran into with their submission for MDMA. So what's difficult to treat depression? And I get asked this question a lot. So John Rush and I wrote a paper, and it's really a terrific paper. And John and I couldn't get this published anyplace. We got turned down by 6 different publications. And anybody that knows John, the other wonderful thing about being an old guy, but working with guys even older than me, is it does make me feel young. John was persistent until we got in someplace. So we got into Australian New Zealand Journal of Psychiatry. And it's really looking at the fact that we need to change the definition of difficult to treat illness, because, you know, treatment-resistant depression suggests that the patient is oppositional to getting better, that they're resistant. We tend to use an acute illness model. When we're looking at chronic illnesses, we're looking at illnesses that really have more in common with diabetes or with hypertension than they have in common with a broken bone that heals up and you go on with your life. The approach is largely biologic and biomedical care, hence, you know, the conversation with Carlos, let's throw a medication at it. You don't have to talk to these people. Whereas difficult to treat depression is complicated because people's lives have changed and they've become dependent on the social welfare system. They have become more dependent on their families. They often develop other comorbidities related to the chronicity of their depression. And we tend to look at the outcomes categorical. Do you meet response criteria or do you not meet response criteria? And one of the things that we've really learned, and hopefully you've also been looking at some of the papers coming out from the VNS Recover study, is we're better off in these severely chronic depressed folks looking at outcome measures having to do with quality of life and functionality more than the MADRS scale, because we don't really expect sleep and appetite to improve. And what improves is your sense of well-being and your sense of attachment to yourself and to the universe around you, which the MADRS, as wonderful as it is, really doesn't capture this. This is also going to be true when we look at outcome measures of psychedelics, because psychedelics offer a potential to change existential despair in a way nothing else other than psychoanalysis may do. And I actually think psychoanalysis is not terribly effective with existential despair. So I've always been interested in special difficult to treat populations, and it's a group of folks with more severe treatment resistance. These are folks who have failed more than 4 treatments and may include use of ECT, TMS, or ketamine. Often there is chronic active or passive suicidal ideation, and I'll give you the first look at a paper I'm about to submit to a journal looking at 20 patients with chronic active suicidal ideation that I dosed with psilocybin, and I'll show you what some of the results are. I've got some data looking at bipolar type 2 depression that has been published, but I'll show you what those results look like. And there's also a number of other things. There's comorbid conditions like social anxiety disorder or GAD or OCD, and there is currently a MindMed study looking at LSD for generalized anxiety disorder. There's a number of substance use type studies, although a lot of the pharma piece doesn't want their drugs in substance use disorder studies yet. And why is that? Because anything that happens in a study before a drug is approved winds up on the package insert. So if I'm doing an opiate use disorder study and weird, awful results tend to happen, it all gets thrown in. So they don't want me to touch it until they have an approval for something. Psychotic depression, likely not to be a good target for psychedelics because of the propensity towards worsening psychosis with these drugs. But all these folks are excluded from existing studies and was given the unique opportunity to do a handful of IITs looking at people who'd failed 5 or more treatments for their depression, the current episode, at bipolar 2 depression, as well as at chronic active suicidal ideation. Again, all populations excluded from almost every other study of folks with psychedelics, although I know Josh Woolley is still enrolling, I believe, in a study looking at bipolar type 2. So what does psilocybin do? It seems to enhance the brain's capacity for change. And I am not the biggest Michael Pollan fan. I'm not the biggest Michael Pollan fan, largely because here's a journalist who wants to be the story. So he was interviewed by Time Magazine, and he spoke about psychedelic research pre and post Pollan. And I'm going, wait, he's not doing any of the research. He's reporting on it, and he thinks he's the magic anyway. But I love the title of his book. It's How to Change Your Mind. And we're really talking about drugs that can change your mind. So it enhances the brain's capacity for change or neuroplasticity, which is diminished across most psychiatric illnesses. The chemical structure of psychedelics is similar to serotonin, and it binds to several serotonin receptors. And the mind-altering effects are presumed to be agonist or partial agonist activity at the 5-HT2A receptor. Co-administration of serotonergic antidepressants can block this activity. How much this is an issue, and this was one of the conversations I had this morning with some of you guys, as to whether people going into a psychedelic trial need to come off of SSRIs. And there was a small study, a 19-patient study, open label, where they said, yeah, you get some efficacy. But I got to say, the efficacy to me was diminished. It was only 19 patients. It was open label, and they got the same sort of results that they got from their randomized phase 2 trial, which I think were not terribly impressive. My own recommendation is I would still try to get people off of serotonergic antidepressants before dosing. Just because I think, I take the look I take at this point in the research paradigm is I have one shot on goal, and I want the ice to have, seeing all the damn hockey sticks in the hallway there, I want as clear a shot on goal as I can get. And I think taking people off of their antidepressants is what I'm doing. Presumably Ziad has a more difficult time than I do of taking people off of these drugs, but I do, and all my studies I've taken people off of their antidepressants. So what are we doing? We're changing the default mode network, and hopefully people know that the DMN is a large-scale brain network, which includes medial frontal cortex, posterior cingulate cortex, and the angular gyrus. It's active when a person is not focused on the outside world and the brain is at wakeful rest, such as daydreaming or mind wandering. And in major depression, there's often a hyperconnectivity in the default mode network and increased activity during rumination. This is actually one of the few areas of the brain that has increased activity in depression. It's also got increased activity in OCD, also has increased activity in PTSD. Psychedelics acutely decrease resting state connectivity in the DMN. This is a picture from Robin Carhart Harris's lab. And let me just walk you through this quickly, because this is sort of why psychedelics are so interesting. So what we're looking at is we're looking at the connectome, basically post-placebo and post-psilocybin. And guess what? Both of these pictures have the same number of connections. Only the connections after psilocybin are going across cell populations, whereas with placebo, it's all staying within those same cell populations. And this is what Robin, when he talks about the entropy effect of psychedelics, this is really what he's talking about. And Robin is a dear friend, and I will say one of the best of the philosophical thinkers about what we're doing with psychedelics. So we're making the brain more receptive to change. We're turning down to the default mode network, which has evidence of hyperconnectivity. And at the same time, we're also increasing dendritic arbor complexity, which promotes dendritic spine growth and stimulates synapse formation. So we're actually even making new synapses. And a possible viewpoint is that we're able to open a door towards psychological growth or change, but we need a psychotherapeutic interaction to foster that process. This has been among the things that psychedelic researchers are throwing sand at each other in the sandbox. And it is related to the fact, depends on what seat you're sitting in. If you're afraid of running into the buzzsaw that Lycos ran into when they were told that there was not a faithful use of psychotherapy during their study, a lot of the companies decided to dumb down whatever their psychotherapeutic support is. And they've changed the language, even to the point that when I showed my suicidal ideation paper to Guy Goodwin, who's the chief medical officer, and again, Compass is not involved with the study or is involved with the paper, but as having been funded by Compass, I share it with them. And, hey, would you think about changing the nomenclature as to what you're doing for therapy? So the companies are trying to dumb this down as much as they can. And there are even some studies going out now that they're trying to offer minimal amounts of therapy. I reviewed one paper recently where they were claiming that they did no psychotherapy in an MDD population, which I think is problematic. I worry that the goal there is what your marketability is going to be as opposed to what your best outcomes are going to be. So do pay attention as to what seats folks are on. So I am the lead editor for the APA is coming out with a book on psychedelics. It will be for those of you attending the next year's APA meeting. I think it's in San Francisco. What better place to introduce my new book on psychedelics is San Francisco, where ever so much of this began. And I decided to call the book Psychedelics. What did I decide to call the book? Basically, I called it Psychedelics Transforming Psychiatry because we have the opportunity to transform psychiatry. And I want to thank my two co-editors, Tricia Suppies and Al Garcia. And it really is a terrific book. I took this from Liam Maudlin, who has been at King's College in London, has also been a dear collaborator, and I asked him to be the lead author for the therapy chapter. This is just a rough guide to how many different forms of psychedelic therapy there are out there. And, for different reasons, you need different things. My suspicion is that there are likely going to be some indications like smoking cessation where the therapy need is small versus the other end of the spectrum is going to wind up being PTSD, where the therapy need is going to be huge and you'll need to redose. But bear in mind, lots of different approaches, but so many of the approaches are predicated on what am I trying to do? Am I trying to make people better? Am I trying to sell my drug? Am I trying to get through the FDA? And that becomes an important element in all of this. So I just wanted to show you a little bit of what the data has been. This is the phase 2 trial from Compass, where folks were randomized to low, medium, or high dose of psilocybin. So this is 1, 10, and 25 milligrams, and we do separate, although not as robustly as you'd think. But I gotta say, I was one of the lead sites for this. I think I'm the second author on this paper. Is that randomized trials where people are dying to get a psychedelic and they don't have a psychedelic experience, it was really hard to keep them in the study. And there are this is one of those studies that I had a lot of angry people who had been either on a low or medium dose because of what their expectation was. And so it is really, really difficult. And I'll also give my introduction to the fact it's really impossible to blind a psychedelic experience. And I don't care what you're going to use as your other drug, but I will assure you, people know that niacin is not going to send them to a special meeting with angels. Almost guaranteed, unless you have, I guess, a severe allergic reaction to niacin.
Was there an open label extension on this trial? I can't remember.
Not on this trial. There was not an open label extension. We put in an open label extension for the phase 3 trials, and there are 2 of them. They have finished, they are doing the data analysis on the 005 study. It does separate, not as robustly as the financial market wanted them to. It separated, actually, curiously enough, about as well as esketamine did in that study. The 006 study has finished enrollment, and Compass did make some big announcement this week that that speeds up their timeline to get to the FDA by 6 to 12 months. So I think they're still planning on trying to get to the FDA by the end of next year. This is the USONA trial. USONA, for folks who don't know, is a not-for-profit company. Chuck Rayson is the chief medical officer, and they're doing research as well. This was not a TRD population. This was a standard depressed population, and they separate much better. But again, not terribly sick folks. And again, really, really hard to, these are expensive studies to do because my personnel costs are unbelievably high. So lots of open questions. Who's the target population? Spent a good deal of time talking with folks here who are planning on doing a trial on folks with borderline personality disorder, and gave some very clear recommendations. I personally think that one of the best discriminating factors in picking folks for these studies is whether their illness is egosyntonic or ego-dystonic. The folks who really, the folks who want to fight, come into my office and fight with me that I don't understand their diagnosis and I don't understand them, those are not your candidates. The folks who are really tired of being sick and tired and really want to feel better and are functioning in the universe except for the awful depression, those are the folks. The folks being brought, and I'll talk about this some more because one of the most revelatory experiences was with my suicidal ideation population. What's the optimum dosing strategy, and does it differ by diagnosis? I think for PTSD, you're going to have to use more than 1 dose. We'll almost guarantee it, because you just can't get far enough with 1 dose. Others may require less doses, and it's really unclear what a maintenance dose or schedule looks like. What are the minimum requirements for psychological support? I think it's there too. It's going to change based on what your disease target is. What are the optimal requirements for psychological support? And a lot of people, and I showed you the slide that Liam did on the different models. I'll very, very quickly tell you what you need to do for the psychological support. You need to introduce people to the concept. You need to introduce them to the concept that they need to let themselves have the experience, go where it's going, and to be open to it, and to go towards problems rather than away from them. And with the integration sessions, the biggest recommendation I have is that the therapy should be reactive and not proactive. You want to go where the patient is and not try to take the patient someplace. They've had a profound experience that they want to make sense of. Give them time to make sense of it. I'll give you one funny example from one of my patients who, at the end of the session, he says, "I didn't have a psychedelic experience." I said, "Okay, what happened?" He says, "Well, it was cold and everything was white." To this audience, obviously, he went ice fishing, right? No. And I said, "Okay, what does that represent?" Oh, I don't have very much in my life. This is a guy who, by profession, was actually a journalist covering religion for a very large news organization. And what he eventually learned, what I said to him is, you didn't have the psychedelic experience you wanted, maybe you had the psychedelic experience you needed. And what he realized, what had happened, is that his life was so barren, despite the fact he was married and had kids, had very little relationship with his wife or his kids. And this really caused him to retool his whole life. He is a different critter since that. So I don't know he would have gotten there without some prodding from the therapist. Is blinding necessary? And if so, how do you blind when there's a profound psychedelic effect? I think that's really, really hard. And I think we're spending too much time worrying about blinding and not enough time worrying about outcomes and worrying about safety issues. The problem is you are not going to effectively blind a psychedelic experience. I have no, and I keep on seeing papers about this. I was just reviewing a paper that somebody had written about it. And the problem is he wonderfully explains the problem and offers no reasonable solution. And the most reasonable solution is going to be with some of the senior folks in the field deciding maybe we need to modernize the way that we look at clinical trials to the new arena that we're in. Because it's a very, very different experience. I've been doing this, let's just say I was just at my 45th med school reunion. So I've been doing this a while. And we have not really updated how we look at things. Is a psychedelic effect necessary? I personally have seen that people who have a psychedelic experience do better than the ones who don't, even at the same dose. But is that psychedelic experience an epiphenomenon, captures the magnitude of the serotonin agonism, or is it a required effect? That I don't know. But I do know that if you've had a psychedelic experience, you're more likely to have bigger drops on some of your scales. As I mentioned, lots of interested parties, each with their own agendas, a desire to own the psychotherapeutic process. So there's a whole bunch of different companies that have set up. I'm sure if you're working with any of the companies, there's a company called Fluence, which Elizabeth Nielsen runs. And I like Elizabeth, but it just sort of feels like it's we're trying to generate some money to do this. A lot of desire to avoid the FDA pitfalls, a desire to make treatment as inexpensive as possible, and a conviction that the psychedelic effect is either critical or not critical. So there's a whole bunch of companies that are trying to have that same effect on serotonin receptors without a psychedelic effect. And as far as I can see, you're just making a different serotonergic antidepressant. I don't think you will show efficacy. I don't think you'll show the degree of efficacy you will with a psychedelic. The available database is still relatively small. Get asked to review lots and lots of psychedelic papers. As you can imagine, the vast majority of them are either commentaries or meta-analyses. And I love the fact that there are 3 studies, so let's do a meta-analysis on the 3 effing studies. So lots of open questions. Really, really commend an article that Roger McIntyre was the first author of that was in American Journal of Psychiatry in January of this year. And I think Roger really laid things out in the best way at the time. And because one of the other problems with the whole field is how often people are way beyond their skis. They're making statements that they are not entitled to. So I'm going to talk about some of my work with my investigator-initiated studies, and these are 3 industry-sponsored trials of open-label 25 milligrams of synthetic psilocybin, COMP360, in cohorts of people with difficult-to-treat depression. One study, 12 participants with a severe TRD with at least 5 treatment failures. So these are folks who are pretty much excluded from every other study. This was published in that same edition that Roger's article was. And curiously enough, I'm not, I don't think it's the most wonderful paper ever written. And it's only 12 patients, open label, winds up in a special edition of AJP on psychedelics. And it was the only novel data in the whole edition. 15 patient study with bipolar type 2 depression with at least 2 different treatment failures. This was in JAMA Psych. I know it dropped. I forget what edition it was in print. I know it dropped like December of 2023. I'll talk a little bit about that. And then I've got a 20 patient study. When I made up the slide, it was still 19. 20 patient study of patients with chronic active suicidal ideation without immediate intent. So these are all folks who were pretty much 3s chronically on a CSSRS. All subjects were carefully screened and records reviewed to support participation. I tapered folks off all psychotropics and med-free for 2 weeks before dosing. Subjects had 3 preparatory sessions, a supervised 6 to 8 hour dosing session, and 2 to 3 post-dosing integration sessions. This is what my dosing room looks like. I've got 4 of these, each with their own bathroom. So we'll talk about these studies. So the first I'll talk about is my severe TRD study, 12 patients, open label, 75% remission rate at 1 week, which was also a 75% response rate, 25% remission rate at 12 weeks, 58% response rate at 12 weeks, lower likelihood of response with comorbid PTSD or absence or a low-grade psychedelic experience. And I'll show you what some of this looks like. So first off, this is what the population looks like. Average age was 40, half male, half female. All of them were white. Generally had been depressed long periods of time. Many of them have been on many treatment failures, but generally a pretty sick bunch. Do pay attention that the PTSD comorbidity, 5 out of 12 of these met criteria for PTSD. Those are also the 5 who were not responders at 12 weeks. This is my spaghetti plot of the, and what you see is a lot of these people really get better. And bear in mind, anybody know what the odds of somebody who has 5 treatment failures, what the odds of them meeting response criteria is with any new intervention? It is low single digits, not counting TMS. But even the TMS studies are really looking at not really folks, they're looking at folks with 2 failures. They're not really looking at the 5 failure folks. The other thing that's really curious is, and this is one of the reasons I'm so close to the ground with research. If you look at that person who has that swing up at the end of the study, the brown one, let me tell you about her. She's the green one. She never met response criteria at any time during the study. And let me tell you who she is. So she is a 32-year-old single woman who is kind of stuck in a graduate program trying to get her degree to become an art therapist. She did not meet response criteria. I discovered later that really she had much worse PTSD than she had let on. What her PTSD was, her mother's Romanian, and mom, in the infinite mom wisdom, decided that her lovely daughter should spend the summer working in a Romanian orphanage when she was 16 years old. And it was a horrific experience. And she had so much vicarious traumatization from this. And at the end of the dosing session, she looks up at me and she said, "I have not been this miserable since I first left that orphanage." She never met response criteria, but let me tell you her story 2 years later. She finished her degree finally, is working as a combination art therapist and CBT therapist. She decided to have a child out of wedlock and is a single mom, is still not happy, and she assures me that she's still not happy. She is functioning at a level far above where she was before the dosing. I don't know what to make of it, but she has a meaningful life, despite the fact that her MADRS score is still abysmal. This is when I divided up whether you had PTSD or not. And this is looking at your MADRS score. And what you see is if you got PTSD, and I'm not saying psychedelics won't work for PTSD. I think the one and done single dosing is unlikely to be of as much help. And hopefully you know that in the MDMA study, they did 3 separate dosings along with lots of therapy for that. And I will say that, like that, my traumatized patient, she did a whole lot better. I think she would do even better if we could treat her more. This is looking at the outcomes on anxiety, quality of life, and functionality at 3 weeks. 3 weeks are our primary outcome measure. And you see pretty profound changes in all these scales. And this is looking at the psychedelic experience versus MADRS outcomes. And what you do see is you see an association. And this is looking at basically a scale that looks at the magnitude of the psychedelic experience called the MEQ. And just the higher the MEQ score, the bigger the lowering of the MADRS score was. Talk a little bit about my bipolar 2 study. Pretty much same design. These were all folks with bipolar type 2. I'm an okay researcher. I'm a really crackerjack clinician. So I can assure you these are all bipolar 2 folks. And not only are they bipolar 2 folks, you know how there are some researchers who just want to know where the center of the target is? I'm one of those researchers who wants to know how wide is the target. So I was looking, so this is a group of folks that actually span between, let's say, bipolar 2.5 and bipolar 1.5. So this was not, you had to meet these very strict criteria. I needed to have a geist of people within this bipolar 2 range. Current episode had to be at least 3 months, no upper limit for duration of current episode. Most of these people had been depressed for months, if not years. Documented failure of at least 2 medication trials in the current episode. And the Hamilton had to be at least 18. Young mania had to be below 10. And excluded for bipolar 1, schizophrenia, psychosis, usual stuff. This is my demographics, and pretty similar. Again, reasonably sick folks. Holy shit. Look at this spaghetti plot. Effectively, 12 out of 15 folks are in remission 12 weeks after a single dose. One of my folks who is a nurse midwife has remained in remission for 18 months, a year and a half after a single dose of psilocybin. She did go back on, as did many of these folks, went back on prophylactic lamotrigine. Generally, very few people had to go back on antidepressants. I actually think that bipolar depression is lower hanging fruit, because the interventions we've got for bipolar depression really suck. We keep on trying to pretend that they're really bipolar 1s, or we pretend they're MDD, and they don't really particularly do well with either the bipolar 1 meds or with the antidepressants. So that's part of the reason why I think we did so well with this group. Here's my MADRS and my QIDS outcomes. So it's not just, and this is the QIDS is the self-rating. So both the rater as well as the patient themselves thought they were doing a whole lot better. And this is my correlation between the psychedelic experience and the MADRS outcomes. And look at my Cohen's D. At 3 weeks, it's 2.6, and at 12 weeks, it's 4.8. All right, let me talk about chronic active suicidal ideation. It's now 20 patients with chronic active suicidal ideation, but no immediate intent. Failure of at least 2 biologic treatments in their depression. I decided to use the scales that we have to follow suicidality stink. So I called up my friend Nolan Williams, and I used the same scale Nolan used for his SAINT protocol, which is the MSSI. It's a modified suicide severity index. So props to Nolan for helping me with that. And this was a sick bunch. The other funny thing I will tell you, it was only after I had dosed these people that several of them came to me to tell me they were even more suicidal than they reported. Because as you can imagine, I don't have a blood test to show how suicidal somebody is. I'm dependent on what they tell me. And I had one guy was a DC-based attorney who had a storage locker largely filled with firearms so that he could kill himself. And again, my Cohen's D's, not quite as profound as the bipolar one group, but pretty darn good with 2s across the board. This is my spaghetti plot. And let me tell you a little bit about this. Probably one of the best discriminants between the ones who get better and the ones who don't. It's back to how many psychiatrists does it take to change a light bulb? Just one, but the light bulb has to want to change. The people who were the most ego dystonic with their suicidality did the best. The people most committed to change. The folks who were less likely to change were the folks not there under their own speed. Mommy or daddy brought them in. They were still dependent on mommy and daddy, largely living in halfway houses because of their suicidality, and at best ambivalent about getting better. They did not do as well. And so, you know, if you were supporting yourself, functioning in the community, had a family, and were miserable, you did incredibly well. If you were living in a halfway house and kind of ambivalent about the whole thing, not so much. That said, I also had a conversation with one of the halfway house folks, with his therapist, and the therapist said, you know, he's easier to talk to now. We can get further in the therapy. So I'm pretty clear that something worthwhile was happening, but it was just the start of a process, and we were not going to capture really what the end result was. As well, the single outcome that best predicted response is if at your day after dosing, if you were still incredibly pessimistic. The ones who were no longer pessimistic got better. The ones who were still very entrenched in their pessimism did not. These are the MSSI outcomes. And curiously, and it won't be a surprise to those of you who are interested in suicidality, we actually do better at suicidality outcomes than the MADRS outcomes. Most of the folks who got better, so effectively, of the 20 patients, 14 of them are no longer suicidal. 6 of them continue to be, and most of those 6 are folks who are not meaningfully engaged in issues outside of their they're halfway houses and they're very insular existences. In MADRS SSI outcomes. And again, the MSI, and I like the scale for this. And you can't really use this CSSRS to follow people. This is the correlation between the MSSI and MADRS outcomes, and they're certainly correlated pretty significantly. Other research findings, you certainly can see enduring effects after only 1 or 2 doses of psychedelic. You need an adequate protocol for administration, paying close attention to set and setting, as that seems to be to lead to improved experience for study subjects as well as better outcomes. Little evidence for unexpected adverse events. I've only had to use rescue meds once, and it was one of those people in my suicidality study who did not tell me the magnitude of her PTSD, but again, after the study, actually on the day of the dosing, her dad had sold her to his friends for sex when she was 5 years old. And I'm so glad I have, for my therapist, I actually have higher requirements than the drug companies I do contracted research with. I want all my therapists to have either PTSD experience or ER experience. I don't want somebody who sat in an office taking care of worried well. She actually met response criteria, even though we had to abort her dosing session, and has done quite well. Lots of changes are not captured by the existing depression scales, and they have a lot to do with well-being, with thinking patterns. Quality of a good subject, realistic expectations, including acceptance of study parameters, ability to connect fairly quickly with the study psychiatrist and therapist, capacity for trust. That is obviously a big problem for a lot of the PTSD survivors. A willingness to accept the experience, trust, let go, be open, and to move toward rather than away from challenging experiences.
What do you mean by acceptance of study parameters?
That I can't dose you because you want to be dosed. I can't category. I can't give you more therapy than the protocol allows. Make sense? This is the only research I've ever done that I have a slide just of comments from my folks. So 1 year after dosing, one of my participants said, my depression's back. What do I do now? I said, hey, happy to help. First, tell me, is anything still better? He said, I still don't hate my parents. And it really suggests a fundamental change in your vision of the universe was persistent, even though the depression was back. 9 months after dosing, before life was in black and white, now it's in color. Before I felt I was sucking air through a straw, now I can take deep breaths. I have more compassion for myself. This is the nurse I had mentioned before, the nurse midwife. She had chronic, vivid, intrusive imagery of horrible deaths happening to herself. These did not disappear, but became more of a detached glimmer, which feels like remembering a previous part of myself that I no longer identify with. Holy. You know, I'm another one of my expressions about my work. A, don't always know what I'm doing. B, never bored. So this nurse's psychiatrist calls me up after she sees what's happened to her patient. She said, you know, I've got bipolar 2 as well. Could I be in the study? And I evaluated her, and she was met criteria to participate in the study. And she as well has gotten all better. She's decided, of course, to become a psychedelic therapist. But what she told me 9 weeks after dosing is meditation finally works. It can put me at ease when I get anxious. So what's captured and not captured by our outcome measures? Mood change, self-criticism, sense of connectedness, somewhat captured. What's not captured? Improved cognitive flexibility, creative thinking, sense of well-being, change in observing ego, particularly getting rid of that very punitive superego. Perspective on self and life events, acceptance, engagement, control over mood state. These folks will still get depressed, but they no longer feel like that it's something they have no effect over, and a sense of stuckness in the past. Other observations, while comorbid PTSD patients do not do as well, some of the longer term outcomes captured significant changes. They may also benefit from more than one dose. Functioning adults with SI did much better than young adults living in halfway house environments due to their symptoms. Do not extrapolate from bipolar 2 to bipolar 1. And when Dost Unger, who's the editor of JAMA Psych, said he was going to publish my article, he said, please do one thing, make it very clear that not to use this on bipolar 1s, because Dost told me that he personally had had experience of 2 folks with bipolar 1 who were made dramatically worse with use of psychedelics. I got to say, some of those interactions with editors I really enjoy because they, it should be an interactive process. Preparatory sessions impact on likelihood of response, and integration sessions may have primary impact on durability. Lessons learned. I don't think we really have our arms around truly capturing the effect on participants. Change in perspective and level of function may be much more critical than changes in vegetative symptoms. Preparation is critical. The more someone accepts that they have to work for change, the more likely a better outcome is. Even before I started doing psychedelics, when I used to do actually a lot of psychotherapy, and what I would tell people is, please don't have the expectation that the hurdle goes away. Please have the expectation that we're going to work to turn an 8-foot hurdle into a 4-foot hurdle. It's now possible to get over it, but you're still going to have to work to get over it. And I think that's what we're doing, is we're lowering the hurdle for some of these folks. Participant selection is key. I spoke to Robin about, folks remember, he had that great study of looking at escitalopram versus psilocybin with the New England Journal of Medicine. And I asked him, Robin, how many folks did you screen to get 59 patients? He said 1,000. Prepare for potential regression given the ego dissolution scene. Like I said, this is why I ain't retired. I'm having a good ride trying to figure this stuff out. As well, I think the utility of psychedelics cuts across multiple diagnostic categories. What I tried to do for this book that I did for APA Press is look at different disease categories, get experts in those categories to talk about use in OCD, use in PTSD, use in mood disorders, use in death and dying, use in improved wellness. So we have chapters on all these things, and hopefully it'll be a wonderful addition to the field. But we need to invent a novel research paradigm to adequately grasp the change in consciousness and mindset that these drugs provoke. But there's a reason our psych programs are now filling, which they hadn't for a number of years, because it's really an incredibly exciting time to be in psychiatry. And I will stop there.
I don't see any questions on the Zoom yet.
Their drugs may not have kicked in yet, Alec. That's the other problem.
The air is changing. So I have a bunch of questions. I bet other people do, but I will. All right.
Thanks for that. I know I picked your brain this morning about, can you use the mic?
That work?
Okay.
I'll have to look over here and you at the same time.
You'll just have to keep me in your mind's eye.
I'll try. So Devin and I picked your brain this morning about our plan for a trial for a single dose with borderline personality disorder. And a bigger question, I guess, perhaps, a lot of the data is coming from what we call episodic disorders, mood disorders. What about the potential for use just generally with personality disorders or kind of longer standing, more pervasive diagnoses?
My best guess is that's likely to be a paradigm in which we're going to have to dose on a regular basis, because it's easy to believe that you're going to slip back into old patterns and that the enlightenment you get won't always be able to be sustained. But when, let's bear in mind, when I'm even looking at these folks with the mood disorders that I've treated in these studies, these were incredibly sick folks with, these are not acute episodes of depression. These are folks with lifetime kind of depressions. We don't know what the long-term course is going to wind up being. What I would certainly try to do with your study is see if you can find a way to have some support to be able to follow people, not just out to 12 weeks, but out to 6 months and 12 months, to see if there are fundamental changes and to figure out what things you want to look at to convince yourself whether there is a sustained change. I once did a study on borderlines when I was still back at McLean, in which we were using, of all things, thioridazine for folks with borderline personality disorder. And I really pissed John Gunderson off because I used his DIB scale to measure changes in those folks. And I wound up making him an author on the paper so he would let me use his scale. But to think about what your outcome measures are going to wind up being, that question is something we don't have the answer to. We haven't really looked at it. But there's obviously this incredible overlap between borderline personality disorder and some of these other disorders, be it the chronic suicidality or the chronic depression I'm talking about.
So just to follow up, you've done it, you got what you're going to get, or is this going to become, okay, I'm coming every 3 to 6 months for my maintenance psilocybin? Because that changes a lot about how the world is going to look for us.
I think it's going to depend on what the disease target is going to wind up being. It is believable to me that for substance use problems, we may be able to limit the length of time and only deal with relapses. For the more chronic things, the wonderful thing about being an old guy is you develop so many effing expressions. And among my expressions is, if you spent your life looking at the world through, pardon my language, shit-colored glasses, even when you take the glasses off, that world still looks pretty brown. And you're going to have a lot of that world still looking pretty brown, even if you've been able to make that depression better. And I think you're still going to be able to speed the process of getting people back on track by setting up a paradigm for redosing. We're not really on that page yet. What I think is going to wind up happening is we're going to need to get one or more of these drugs on the market, and with there a revenue stream that can support looking at more of the long-term durability issues. But the initial take, my buddy Tricia Suppies did have a look at veterans who she had dosed and followed them out a couple of years, and it was amazing how durable some of their responses were.
I'll ask a question. So a question from the Zoom chat is, our researcher who studies adolescence and creativity as a means to relieve depression wants to know, say more about what patients said about creativity. What changes, what doesn't?
I think, and Katie, it's a terrific question. I think that what you're doing is you're taking kind of the superego restrictions on somebody's thinking pattern. So I think there can be more vivid thinking. What I'm about to say, I'll probably regret, but there's a reason that the music from the late 60s, early 70s is different. And it's different than any other music that has come out since. because that first exposure to psychedelics and how much of the Beatles' oeuvre is really coming out of psychedelics. But I do think that there is a creativity that can be enhanced. I don't, admittedly, I'm not one of those people that really wants to look at use of psychedelics as a lifestyle choice. I'm trying to treat people with really serious illness. But there's also this incredible crossover between the magnitude of psychiatric illness within creative people. Years and years ago, there was when the drug companies could still give us all kinds of stuff. And one drug company had decided to send us audio tapes from all these composers who had ever been diagnosed with a psychiatric disorder. This did not limit the selection much at all. And another friend of mine is a psychiatrist and pianist Rich Kogan, who actually does presentations on the psychiatric illnesses of various composers and shows what their effect on the music is. And I do think that by taking some of these people out of despair, you likely can increase creativity pretty dramatically.
Yeah, thanks for the really great talk. I'm interested in the comments that you made about openness to change, openness to the psychedelic experience, and whether there are good screening tools that exist for that, for participant selection on the front end, or rating scales, whether they're self-report or interview rating scales for kind of tracking that and how that, in sort of a data-driven way, to look at how that may be affecting things or kind of trajectories.
Great question. At this point, I will confess I'm much more dependent on my interviews with the study subjects and how they relate to me. And I think I can tell a lot from those interviews. How we're going to capture that on a scale, I'm not sure. But like I was just telling you before, the people who want to come in my office and fight with me are not the candidates. And that represents a sizable number of folks with personality disorders, because their geist is warmed through friction and they need to create friction. That's unlikely to be the best setting, at least to start with this. But I dare say, once things get approved, we should think about how do we make somebody ready for psychedelic treatment. And there's a paper that Liam Maudlin, who did my chapter on the psychedelic therapy chapter, has a paper that I'm the senior author of that's in Journal of Affective Disorders just on that psychedelic readiness. And that was supposed to be the preamble to developing a scale, which we never got to, but that at least goes into what the thinking process is behind what that scale is. And it was in a special edition of JAD on psychedelics.
I think that was going to be one of my other follow-up questions is, okay, if patient selection is so important, how do we avoid blaming the patient because I think that this is something that comes up in a lot of trials is, oh, well, the patient just wasn't ready.
But I think it's our goal to make them ready.
That is a great point. Thank you. This was a most exciting talk, Dr. Aaronson. I'm coming from the psychotherapy perspective. I'm a psychologist. I work with Ziad's team on TRD. So to me, I look at this through the lens of how can psychedelics assist us with the psychotherapy. And you mentioned a few different things. So my question is mechanistic. And I'm very excited about the idea of increasing cognitive flexibility, because that is the obstacle in our treatment a lot of the times, is that people have this, especially in TRD, right? They have this outlook of nothing's going to work because it has been true. And that's one of the things that we're trying to at least stir up and ask them to consider, that maybe there is something that could be done. So You said that the psilocybin can enhance cognitive flexibility and neuroplasticity. And then on another slide, you were talking about how in the psychotherapy, you see it more beneficial to have it patient-driven rather than therapist-driven. And I found that curious, and I wonder if you could talk more about this, because we have camps here represented of psychotherapists who do more structured, let's help you with the change, and others who are more bottom-up, like dynamically oriented and allowing the patient more to drive the process. Do you feel strongly about how much the therapist should guide, or yeah?
And what's going to happen as this rolls out, you will have as many different opinions as there are psychologists doing the therapy. And I think that what you want to do is you want to be respectful of the patient having a unique experience that you ultimately know nothing about. So you are likely to benefit the most from your own perspective, as well as from the patient's perspective, to first understand what that experience is like, and to see if you can help them craft meaning from that unique experience. And because there are lots of directive therapists who tell people what to do, and that's not what I think psychedelic therapy should be. I think it should be respectful of a unique process. And I will just say that I don't think I have been more changed by anything I have done in psychiatry as much as supervising a psychedelic research program, because I see change in a way that I've never seen change before. And I think our goal is to get out of the way and to help people not trip over this. And, and to a certain extent, it seems odd, but, it's kind of like, to me, explaining to somebody what being a parent is like. Or I remember I had to take the board exams before I had kids. And I remember taking the board exams, and there were questions on child development, when children walk and talk, and I'm sitting there thinking, and if I had just taken those damn tests 2 years later, no effing problem. And I do think that I would love for you to have the experience of seeing what this is like for folks, because it becomes almost intuitively obvious if you don't go in with a definite mindset as to what you're supposed to be doing. If you sit with somebody and to talk about what that experience is, the experiences are unique, they're individual. When I was a medical student, I thought very seriously about being a surgeon. And what you'll see is there's a lot of psychiatrists who thought about being a surgeon. Very few surgeons thought about being psychiatrists. And what those of us who want to be surgeons, we wanted to be intrusive in some way. And I think that we have an opportunity to look at how the mind works in a way that is just so unique. And I will also tell you that everybody's psychedelic experience is different. I'm thinking about being an orthopedic surgeon, going, how many different ways can you break a leg, and how many different ways can you put the damn screws in? And I've been a psychiatrist with difficult to treat depression for 40 years post-residency. Man, it is always different. It's a different trip. And this is another level of difference that you're going to wind up seeing. And helping people figure out a path ahead based on what's happened to them is the way to look at it, not imposing your mindset as to this is the way the post-dose therapy should be. That's my take.
I love those comments. I'm another one of those psychiatrists who gave serious thought to surgery residency.
I've always had that thought about you, Sophia.
But I love what you're saying, and I loved your opening slide about this really rethinking kind of these difficult to treat depressions as a recovery story. I do work in psychosis, early psychosis, and that has, of course, become the mantra. And so what you were just saying now about the client defines recovery. The client tells you about what was their unique experience going through those episodes of psychosis. You don't impose on the client, this is what, we're going to reduce all your symptoms. And that's our main goal. The client will tell you what the goal is, where they want to be in 6 months and 1 year and 2 years, and also how they're going to interpret being psychotic or having a chronic psychosis, right? Maybe it's part of their creativity. Maybe it's part of what allows them to be, have a different view on the world and so forth. So it's very interesting to me. I guess I never realized that is not a major paradigm within the work within depression. So I find that very interesting. But the other thing that has struck me, and it fits in now with these comments you're making and this idea of the client driving the work, the interpretation, the experience, is really, you have pointed out the key importance of motivational systems. Motivation as a psychological construct, of course, for engaging in the psychedelic assisted treatment. But I'm also thinking of motivational systems as neurobiological systems, neurocomputational systems, which vary a great deal from individual to individual and probably play extremely large role in functional outcomes, regardless of diagnosis, right? So you can have someone with a very severe persistent psychosis, but if they have some motivation to have a life, to have relationships, to find work, they're going to end up doing fine functionally, right? Same thing for depression, same thing for OCD, et cetera. And for me, it's another one of those shifts we have to be thinking about in psychiatry, which is, and it's kind of the comment you were making to Sabina just now, our job is to help the client find their motivational juice, if you will. How do we harness those motivational systems, which we can do behaviorally a lot? Maybe eventually we're going to be able to do it with pharmacologic enhancement. But in some ways, that's the key to helping the individual unlock how they're going to move forward. So I don't know that I have a question for you, except to ask, have you been thinking kind of at that more, what do you say, global level about, as you work with individuals, as you're doing your interviews, assessing them, whether they're going to be appropriate candidates or not, do you actually explicitly think about, again, sort of where are they in terms of their levels of motivation? Whether you think about it in terms of a biological phenomenon or a psychological phenomenon.
I tend to look at it as a psychological phenomenon. I want to underscore something that you're saying, though, that is where psychiatry has to go, which is to stop treating illness and to really treat people. I was not the biggest fan of that movie, Patch Adams, but there's a line from Patch Adams that I just love, which is really what you're talking about, which is you treat illness, you win some, you lose some. You treat people, you always win. And what you're really talking about is, even with the psychosis folks, that we're treating people, not an illness, and that the goal of treatment shouldn't necessarily be the extinguishment of all psychotic symptoms. It should be helping people get the life that they want to have, because there's a lot of folks who are functioning with psychotic symptoms, and they may have better lives than the ones that we spend all of our time trying to extinguish everything. I do think that we're looking, I hope, at an enormous paradigm shift, because Sophia, not everybody agrees with us. And even when you look at that example from Carlos, love Carlos, great friend, he's looking at what drugs can do to an illness. He's not really looking at, how do I make this person as good as I can make them?
Corollary of that is, if you are going to try and harness someone's motivational systems, whether you're thinking about it psychologically or biologically, you do that by giving them autonomy, right? That's like a fundamental precept. There's decades of research on that. You promote autonomy, you promote belonging, you promote competence. and then people experience intrinsic motivation, and then they're going to be more engaged with whatever it is they're choosing to engage with. So I think that's part of this paradigm that we have to be explicitly talking about.
And what's curious is the people who do the least well are the least autonomous. So I have to say to discover a kindred spirit, always a very special pleasure.
Hello, hi. So I had a question about your study on suicidal ideation on the participants you were working with. Are they primarily people who have experienced ideation their entire life, which would maybe explain like the differences in the treatment effectiveness, or?
Largely, most of the folks that were in that cohort are people who have been suicidal for most of their adult lives. From another study, I had somebody who was in my VNS cohort who Chuck Conway wanted to exclude because he was too suicidal. And I said, hey, we got nothing to lose. He's effing miserable. And saw him at his 4-year visit just on Monday, just before I left for here. For the first time in his adult life, and he is 70 years old, and this has only been starting year 2 of VNS, he no longer has any suicidal ideation whatsoever. So the folks I'm looking at these are not casual, I occasionally think about suicide. These are folks who, my criteria in the protocol, and you could say how effing nuts I am based on how I wrote this criteria, that they think about suicide on more days than not in the past 6 months. So these are generally people who have been suicidal for years. And it's a part of their makeup. And that's the other very, very difficult thing within all of psychiatry. I am very, very grateful that Compass let me do this study, because a lot of people who saw this study, even my own IRB that I had to go through, are going, "You sure you want to do this?" And when I first got down to Sheppard Pratt, they had me meet with our risk manager. And I told her I wanted to look at suicidality, and all the color went out of her face. And it's this odd thing that we can't look at it, because if we get a bad result, it'll be our fault. And the point is when you look at suicidality, and we've got all these new treatments for depression, have we moved the needle at all in terms of the incidence of suicidality? No. If anything, it's gotten worse. God bless social media. So these are really suicidal folks. If anything, they wouldn't qualify because they were more suicidal than they let me know, and they have contended with this for most of their lives.
And I guess a follow-up question, it's not directly related to psilocybin, but do you find after the suicidal ideation has kind of gone into like remission, is it mostly like they still have these habitual thoughts, but it's easier for them to like kind of push them away? Or has there been people that have been treated where it's not even in the background of their mind anymore?
For a lot of these folks, and I'll now talk about Joe, just because I had seen him more recently, and he's the VNS guy. And I asked him exactly those questions. He said it's just not even there. And he's now in a relationship with somebody and had avoided having relationships because he didn't want to subject his suicidality to a partner. So we're going to see it all over the map. What is so nice is we're finally looking at it. But the problem, of course, is we don't have the right way to capture it, because we don't even have the right nomenclature to discuss suicidality yet.
Yeah, thank you. That was very interesting.
Like I said, just trying to make psychiatry suck a little less.
We got time. We got time.
Hello. Okay. I have a very specific question. So obviously psilocybin is not a good candidate for people who are experiencing psychosis, like you said. But you mentioned a veteran study and you're doing a lot of PTSD work. So I was interested if you have exclusionary criteria for PTSD patients who also have psychosis, or if they participate and you've noticed specifically like any escalation or de-escalation of like paranoia, delusions, things like that. I'm just interested in how that would.
Yeah, for the time being, we're excluding from all studies anybody with a clear psychotic diathesis.
Okay, yeah.
Whether it's related to PTSD or not. And it's not something I think we should forever avoid, but I'd like to do it from a better knowledge standpoint. So I right now, I want to be careful. I want to know, again, how big the target is, but I have avoided going down the psychotic pathway. That said, if somebody gave me funding to look at non-psychotic bipolar 1s, I would seriously consider doing it, would try to put some safeguards in place. The funny thing about the bipolar 2 study, I expected to see I was going to flip somebody. I did not flip anybody. The only person who developed anything in any of my studies that suggested some kind of flip, one of my severe TRD folks developed a persistent insomnia that lasted 3 weeks that I could not affect no matter what I tried him on. But that was the only person, and no history, no family history of bipolar disorder, nothing like that.
I think that's probably about where we wrap it up. Thank you all for coming and for, I think, this is one of the longest question periods we've had in Grand Rapids.